All right, I can't do anything but thank all of you for hanging here to the very end. Hopefully, last is not least. I don't think it's going to be. It's certainly a very important topic that relates to the practice we all have in our primary care clinics and ultimately sometimes in the hospital too. So the topic before us is the plate debate. Which approach is better for the management of obesity and cardiometabolic risk? Boy, how about that for ending this meeting? So we've got three speakers. The first is Monica Aggarwal, who's going to present virtually. The second is David Ludwig, and the third is Holly Wyatt. Monica's from the University of Florida. She's a cardiologist. David is at the Boston Children's Hospital, Harvard Medical School, and Holly you've met already. She's a professor of medicine at the University of Alabama, Birmingham. So I'm going to ask David Ludwig to come up and make a few comments before we get going. These are relevant and important.
First slide, please. On behalf of the organizers, it's my honor to dedicate this session to Sarah Hallberg, who tragically died 2 weeks ago. She was supposed to be a speaker at this session. Sarah was an extraordinary person. She dedicated her life to reversing, what you called reversing type 2 diabetes by diet. She did so in, why is the slide not moving forward?
Yeah, we got it, okay.
She did so in conventional ways. She founded the medically supervised weight loss program and became an adjunct professor at Indiana University. But her advocacy extended beyond these traditional venues to a TED Talk, which acquired more than 8 million views, 145,000 likes. That's really extraordinary. She wrote an op-ed in the New York Times, it was featured in the Sunday paper on novel dietary approaches for type 2 diabetes. And she helped found the company Virta, which is providing alternative and intensive supported nutrition and behavior counseling for people with type 2 diabetes. Thousands of people are being affected. So Sarah was really beloved by all who knew her, and I'd like to just close by hoping that her memory be an inspiration and a blessing for all of us.
Okay. Thank you much, David. Sarah was to be speaking in the position David's now in, so he at the last minute was willing to change his plans and be with us today. So David, thank you, and we all miss Sarah for sure. So Monica, you're on at a distance. We'll look forward to your talk, and hopefully you'll be part of our ongoing presentations as we continue. Monica.
Talk today about plant-based diets and whether they're good for cardiometabolic health. I have no financial relationships. So we all know in the primary prevention guidelines, there's a goal to emphasize adherence to a healthy lifestyle, arguably before we start thinking about intervention or medication. In fact, the guidelines, as been in the previous talk, have been so nicely discussed. There was a focus on reduction of cholesterol, blood pressure, but there's also an emphasis on diet within the primary prevention guidelines. In the secondary prevention guidelines as well, this is from the ESC, we are reminded that patients who are at high risk or do have ASCVD do have residual risk in terms of inflammation, thrombotic, high triglycerides, elevated Lp(a), diabetes, and cholesterol. And as well in the prevention guidelines and in other studies, you're reminded that poor diet quality can lead to multiple risk factors and then is associated with higher amounts of cardiovascular disease. So shouldn't this be a focus as cardiologists and as physicians on treatment, and shouldn't we be focusing on nutrition? Well, how many of us actually talk about nutrition in our daily practice? When we evaluated this, about 62% of cardiologists spend less than 3 minutes of their clinic time on nutrition counseling. The problem is that most of us as physicians and as cardiologists know very little about nutrition. We didn't learn it in medical school. This is a survey that we did that shows that only 1% of doctors felt that they received a high level of nutrition education that gave them excellent skills for counseling patients. And over 90% of cardiologists felt that they received minimal to no nutrition education during their fellowship training. So what is it that we should know? What should we focus on? Really looking at this from JAMA, which shows the state of US health and what are the risk factors. And you can see risk factors for mortality and burden of disease, and you'll see that dietary risk is the #1 cause, and that's mostly driven by cardiovascular disease. What's wrong with our diet? Why should we be worried about it? And why is there, people call it the SAD diet or the standard American diet? Well, it's high in the consumption of red meat, refined grains, processed foods, high-fat dairy, non-nutritious calories from high-sugar sweetened beverages. Currently, 0.9% of adolescents and only 2 to 3% of adults obtain their daily recommended fruit and vegetable intake. Almost 75% of packaged foods in the United States now contain added sugars, and then most of that comes from sugar-sweetened beverages. Not only is the food quality change, we're also feeding people more of it. In 1950s, you would see a burger that was 3.9 ounces, and now that same burger is 12 ounces, similar to a soda that was 7 ounces and is now 42 ounces. So does it really matter? So what if we eat the way we do? What do the guidelines mean that we need to focus on diet as part of our prevention guidelines? Why should we focus on it? Does it matter? There's so many of our patients, as we've heard, that say that, oh, my dad had a heart attack at 45. That's my future. And this is a slide, and probably my favorite slide, because it talks about genetic risk and whether lifestyle matters. So just to review, the x-axis has genetic risk, low, intermediate, and high, and calcium scoring on the y-axis, and favorable lifestyle in blue and unfavorable lifestyle in red. And you can see that people who have a low genetic risk and they have a favorable lifestyle, they're going to have about half the amount of calcium than somebody who has a low genetic risk and an unfavorable lifestyle. Well, similarly, looking at the high genetic risk patient, if you look at somebody with an unfavorable lifestyle versus a favorable lifestyle, you can see that you can have a 50% reduction in theory by improving your lifestyle. So my goal at this point is to focus on plant-based diets, which was my task. And I wanted to first start with a definition, because I think that people lump these together and they're not all the same. And within this, there's actually even more variety. The DASH study, or the DASH diet, is the Dietary Approaches to Stop Hypertension diet. That's actually a diet that's primarily plant-based, with fruits and vegetables, low-fat dairy, nuts, legumes, fish, and fiber, and includes less red meat, no processed meats, minimal sweets, and saturated fat. A vegetarian diet, or some people call a lacto-ovo-vegetarian diet, is a diet that is fruits and vegetables, grains, beans, eggs, milk, and cheese. A vegan eats no animal products and won't even eat honey and often won't wear it. This is an ethical decision. That doesn't necessarily mean they're going to be eating healthy vegan food. Remember, Oreos and potato chips are vegan. And then somebody who eats a whole food plant-based diet typically will eat a whole grain fruit and vegetable diet, whole foods, and no animal products. All of the plant-based diets are high in carbohydrates. Ideally, these are complex carbohydrates. So just to remind everybody about the DASH study, and the DASH study was done on patients with 459 hypertensive patients. And when they looked at the patients, they compared a diet that was the DASH style, which was high in fruits and vegetables, low in fat and cholesterol, to people who were eating a low fruit and vegetable and dairy product diet. And you can see that within just a couple of weeks, so here red being the enriched one, green being the low fruit and vegetable diet, you can see within 2 weeks there was a significant drop in blood pressure by changing somebody's diet. With the second DASH study, which looked at the DASH sodium, which was when we basically took those patients who were already on a DASH diet and then assessed them based on sodium level. This is high, intermediate, and low sodium level, and again, blood pressure on the y-axis. And you can see that just having them on a DASH diet, so here's the control, and then if you cut down on the DASH diet and further reduce their sodium, you can see a further drop in their blood pressure. So why does it matter again? Because remember, our medications are great, and never to undermine the value of the medications. ACE inhibitors can drop blood pressure 12 millimeters of mercury, calcium channel blockers 13. Just dropping somebody's sodium and somebody has high blood pressure drops somebody's blood pressure 7 millimeters of mercury. But what if you have somebody on a DASH diet without dropping their sodium? You can drop blood pressures 11 millimeters, and DASH with low sodium drop blood pressure almost 21 millimeters of mercury. So while medication works and is great, a medication diet is even more impressive. Remember that after the DASH study, the Omni-Heart study was done, which actually looked at a DASH style diet and then tried to adjust the carbohydrates, and really sort of one diet was, they had a carb-rich diet, which was DASH style, a DASH style that actually switched out some of the carbs with protein, half of which are from plant sources, and then a diet that was rich in unsaturated fat, so high fat, high protein versus high carb. And what you can see here is that the benefit really was in terms of triglycerides. So for people who are suffering from higher triglycerides, it's important to appreciate that they could switch out some of those carbohydrates with protein and fat, but clearly we will discuss over the course of this about protein and unsaturated fats. What I also like to point out about the DASH diet is that for each 5-point increase in adherence to the DASH style diet, it was associated with a reduction in mortality, in CVD mortality, stroke mortality, and in all-cause mortality. So the goal in terms of fruits and vegetables that we want to see is that we want to see people eating at least 5 servings of fruits and vegetables per day. And remember, a serving is not 3 strawberries. It is 1 cup of uncooked vegetables, 1/2 cup of cooked vegetables, or a baseball-sized fruit. Just to go further and sort of look at diets other than the DASH diet, well, what about a vegan diet? So a low-fat vegan diet. And this is a study done by Neil Barnard, where he looked at patients who were kind of low-fat vegan diet compared to an American diabetic diet. And these are people who had type 2 diabetes. And what he was able to show is by shifting them over to a low-fat vegan diet, he was able to see the significant drop in weight, LDL cholesterol, urinary albumin, and an A1C of 1.23. And that's important because remember, metformin can, at max, can cause has been shown to drop A1C about 1 point. This is the Adventist 2 study, which shows that looked at non-vegetarians, and we'll look for brevity, we'll look at non-vegetarians, lacto-vegetarian, and vegans, and looked at body mass index, diabetes, and hypertension. And you can see that with the body mass index for the non-vegetarian to lacto-ovo to vegan is a significant drop, but look at the diabetes rates going from 1 to 0.39 to 0.22 for the vegan, and even the blood pressure is significantly dropping. This is a study that came out of NYU that talked about inflammation, because inflammation is the hot topic in heart disease, as we know. And this looked at 100 patients with heart disease who had CAD and that came into the cath lab for PCI, and then were randomized to a vegan diet versus the AHA recommended diet. And what they were able to show is that the patients who went on the plant-based vegan diet actually had a more significant reduction in their hsCRP than people on the American Heart Association diet. This is an old one, but good one and important, because this is the Ornish study, the lifestyle heart study, where they looked at secondary prevention patients. So 48 patients with moderate to severe heart disease, and did intensive lifestyle changes. So they were on a 10% fat veg diet, so low fat vegetarian, but not vegan. And they added so many other components, which again is has become the foundation now for cardiac rehab or intensive cardiac rehab, where they added aerobic exercise, stress management, soaking cessation, and psychosocial support. Importantly, he was able to show that 35 people completed the study. He attributes that, and many attribute that, to because there was so much joy in this group and they followed through this program through a cohort. Recall that many traditional cardiac rehabs have about a 35% retention through the program. What he was able to show, and this is in the baseline, and this is in years, and the y-axis is diameter stenosis, was able to show that patients who were on the treatment, which is the intervention, they had at least, if not a reduction, they definitely did not have a worsening of their heart disease, whereas people who were in the control group had progression of their heart disease. Now, there are criticisms of this study for sure, because the patients on this diet during this time were not on the medical therapies that we have at this time. And so because of that, likely the curves are more sharp and likely would not be as sharp today. But I think it's important to emphasize the benefits of dietary change. This is a one person, but it's just so impactful, and so I really like to show it. And this is a nuclear stress test on the left in a patient who had heart disease and was decided that they did not want to be on a statin and wanted to try dietary change. And you can see that there's a defect here in this nuclear perfusion stress test. And within 3 weeks of changing their diet to 100% whole food plant-based diet, there was improvement in perfusion. You can see the cath as well on the left here. And after 32 months, they actually cathed this patient and showed so much improvement in their coronary artery. Obviously, one point patient, but just so impactful. So I'd like to point out a little bit about the Mediterranean diet while we talk about plant-based diets, because truly the Mediterranean diet is a plant-based diet. If you look at the foundation of the diet, it's fruits and vegetables, grains, mostly whole grains, olive oil, beans, nuts, legumes, seeds, herbs, and spices. Yes, there's fish and olive oil and some, but this in the no-go zone is really the poultry, eggs, cheese, meats, and sweets, and the foundation is a plant-based diet. There are 3 main studies that talk about and focus on the benefits of the Mediterranean diet. The first one being the Lyon study, the Lyon Heart Study, where in secondary prevention patients, by putting patients away from the standard diet and putting them on a Mediterranean style diet, there was a 69% reduction in cardiac death or non-fatal MI. They assessed the data at 27 months, but that effect continued to extend out to 46 months. And of course, the famous PREDIMED study, which was a primary prevention study. These are patients who had high-risk disease, 3 risk factors, and they were on the control diet versus a Mediterranean diet with nuts or a Mediterranean diet with extra virgin olive oil. And they were shown to have a significant 30% reduction in the composite endpoint. And this was primarily driven by stroke reduction.
Yeah.
What I like in particular is to focus on, well, what about those Mediterranean patients? What did they specifically eat? And if you look at this is if you look at quintiles of adherence to a pro-vegetarian pattern and mortality rate on the y-axis, you can see that the people who adhered to the most pro-vegetarian pattern of the people on a Mediterranean diet were the people who had the lowest mortality rate. To remind you from Lancet that carbs are not our enemy, that when you eat carbohydrates, the optimal amount of carbohydrates is about 50 to 55%. We don't want people to be eating a lot of carbohydrates, because if you're eating 80% of your diet as carbohydrates, then you're going to be eating primarily a lot of refined carbohydrates. So, but we also don't want people to be eating, a low carbohydrate diet as well, which is also associated with higher events. But then why did Time magazine say that we want you to eat butter? Scientists labeled the fat the enemy. Why were they wrong? So, and then later on we have the PURE trial, which is Salim Yusuf's group, and he looked at and he commented that high carbohydrate intake was associated with higher rates of mortality, whereas total fat and individual types of fat were associated with lower mortality. Wait, what? That's totally opposite with what I just said. So that requires us to look a little bit at the ketogenic or very low carb diet. Classically, if we look at a low carb diet, which is what LC is, we're typically looking about 74% of that diet is usually fat, and sometimes that could be up to 100 grams of saturated fat per day. This is a study that's from unpublished data looking at people on a ketogenic diet, and there's such variability in the LDLs in these patients. And you can, so while some people will say that they have had a significant reduction in their LDA, we see quite a bit of variability in that LDL with a ketogenic high-fat diet. Plus, we have so much data over the last 30 years that remind us that eating high dietary intake of saturated fats is associated with increased rates of coronary heart disease. Dietary recommendations for the prevention of heart disease should really focus on replacing total saturated fat with more healthy sources of energy. We have multiple studies that remind us that switching from saturated fat to polyunsaturated fat is optimal. So just to remember, here's the unity line and the multiple studies here on the left, and we want to be on the left side, and just switching over from saturated fat to unsaturated fat was impactful in terms of relative risk. This is a slide I love from the NLA, which really looks at fat and mortality. And again, here's 0, which is again that middle zone or unity line, and we want to stay below that 0 mark. And you can see that when you eat fats that are high in trans or saturated fat, that we want to, these are bad or were associated with higher mortality versus mono and unsaturated fat are associated with lower mortality. And if you focus here and show that substitution of saturated fat with trans fats, yes, we actually worsen mortality. But if we take saturated fat and change them to unsaturated fats, we actually improve mortality. But what about with carbs? Okay, so saturated fats, and if you're eating saturated fats and you switch them to refined starches and carbs, you make people worse. But if you take saturated fat and you replace them with whole grains or whole grain carbohydrates, you make people better. So what matters is what you replace the fat with. It's not that saturated fat is good. It's that if you replace saturated fats with a refined, low fiber meal like this pasta dish that you might get at something like Olive Garden, you're going to make the patient worse. But if you take the saturated fat and you replace it with a whole food, whole grains, whole beans, you're going to make the patient better. So in our editorial that we wrote in regards to commenting about the PURE study, we said it's not that saturated fat is good and that carbs are bad, but rather that saturated fat is bad and refined simple carbohydrates are as bad, if not worse. So it matters what carbohydrate you eat. We want to focus on carbohydrates that are complex, whole wheat breads, brown rices, beans, lentils, and stay away from simple carbohydrates, which are the ones on the left. And to really not focus so much on whether people eat Mediterranean or 100% plant-based, but to remember that we want people to just eat more plants. It can either look like this or Mediterranean or whole food plant-based, but certainly not looking like this. Is there such a thing as a bad plant-based diet? This is an article that came out in JACC in 17 looking at plant-based indices and hazard ratio for heart disease, and here is the unity line right here. H is for healthful plant-based diet and U is for unhealthful, so this dotted line is the unhealthful plant-based diet and the red is the healthful plant-based diet. And to remember that you want to be below the unity line, and you can see here that the red line, or the healthful plant-based diet, is associated with reduced hazard ratio versus the unhealthful diet, plant-based diet, is associated with worsened mortality. So again, just to remember that we really want to stay below here in terms of complex carbohydrates, but low saturated fat and higher in unsaturated fat. And we want to stay on the left side of the curve of this line here and not on the right. All are many of which are plant-based on the right, but which are unhealthy foods. And that's why the prevention guidelines in 2019 really do emphasize that as a class 1 indication is that a diet should be emphasized that is high in vegetables and fruits, legumes, nuts, whole grains, fish, and that those are recommended to decrease ASCVD. And really any focus on any diet that's not the standard Western diet, that's more plant-based, is the key. If you look at the alternate healthy eating index, the Mediterranean DASH diet, any of these dietary changes away from the standard American diet will cause an 8 to 17% reduction in death from any cause. And just another last slide to look at the components of a diet to see and their association with event rates. You can see that when you look at processed meats, I think we're all officially can say that those are really the worst, but even that refined grains really is quite high on the list. Dairy, but then you start getting into the better foods here: fish, fruits, vegetables, nuts, and whole grains. So it's not that carbohydrates, again, are bad, it's just that what kind of carbohydrate you give somebody is the key. So you have two choices. We could perform triple bypass surgery where we take a vein out of your thigh and open up your chest so we can sew the vein onto your coronary artery. This costs more than $100,000 and will keep you laid up for at least 2 months. Or we could put you on a vegan diet. A vegan diet, GDOC, that sounds pretty extreme. Thank you so much.
Okay, thank you very much, Monica. We're going to turn to David Ludwig now. Now, Monica's talk really emphasized, I think, the quality of the diet. So I think what we're going to hear now going forward from David is how macronutrient composition reflects on weight maintenance versus weight reduction. David?
Thank you, Bob. These are my disclosures, most notably royalties for books that recommend a carbohydrate-modified diet, although not specifically a low-carbohydrate diet. The first law of thermodynamics proposed by this German Rudolf Clausius says that energy can neither be created nor destroyed. applied to body weight gives the familiar equation calorie intake minus expenditure equals calories stored in the body, which is mostly body fat, our main energy storage organ. Now, this law has been used to explain obesity, such as by an endocrine society statement, scientific statement, which concluded that obesity pathogenesis involves sustained positive energy balance with energy intake greater than expenditure. The European guidelines for obesity management concluded that at the simplest level, obesity develops as a result of a period of chronic energy imbalance. And an expert panel of many associations, including the American Heart Association, said that to achieve weight loss, an energy deficit is required, and considered this high evidence strength. Now, I'm going to argue that that equating a positive energy balance with obesity is meaningless. It's a waste of time. It's a tautology that tells us nothing about biology. It's like conceptualizing fever as a problem of positive heat balance. Too much heat in the body, not enough heat out of the body. Well, of course, we all know that to generate a fever, the body has to create more heat than it dissipates. But that's so obvious, we don't need to start textbooks on febrile illness with this law of thermodynamics. We don't have to inform patients of it. What's critical is to understand cause and effect. The first law of thermodynamics is physics. It doesn't tell us anything about cause and effect. To understand cause and effect, we have to ask what comes first. Does the positive energy balance cause fat storage, cause weight gain, or the opposite? Does increasing adiposity drive a positive energy balance? Both of these are perfectly consistent with the law of thermodynamics, but they have radically different implications for how we would think about obesity and how we would treat it. Now, the conventional way of thinking has the arrows going from left to right, so that in our modern food environment with ubiquitous tasty foods, it's easy to overconsume energy. We don't burn it off with our sedentary lifestyle. Those calories build up in the bloodstream and get forced into fat cells, making them anabolic, making them grow, and we gain weight. The simple solution, we've heard it 1,000 times, eat less and move more. And the ultimate manifestation of this, or translation of this paradigm, was the first food guide pyramid, 1992, which focused on reducing fat. Fat is the most energy-dense nutrient, and it's considered very tasty. So the thinking was that by reducing fat and increasing carbohydrates, we will automatically be shifted toward a negative energy balance. These are quotes from the era. I'll just cite one in the interest of time. A group of experts said, when people are allowed to eat from ranges of high fat or high sugar foods, passive consumption only occurs with fat. It follows that fat promotes overconsumption, while sugar probably prevents it. Now, this is only 25 years ago. Of course, things haven't worked out well. Calories from fat as a proportion of our diet decreased as expected. The proportion of our diet as carbohydrates increased, but obesity rates skyrocketed during that time. In fact, meta-analyses of low carbohydrate versus low carbohydrate, high fat versus low fat, high carbohydrate diets consistently show that the low fat diets are inferior. Now, these are not big differences. They tend to be in the range of 2 to 5 pounds over 6 months to a year, but these are low-intensity behavioral studies that don't show the maximum effect. This is the opposite of what was thought, that just because of that high energy density and that tastiness, we should automatically be moved toward a better energy balance. So we have to ask, why hasn't this paradigm, which sounds pretty straightforward, failed? Well, one reason is that it's based on an erroneous target. Remember that fat is energy dense and tasty, but there's no evidence that energy density affects chronic body weight or appetite or food intake control. Certainly in the short term they do, over days to weeks, but over the long term there's no evidence for it. One study, the largest, took 2,700 patients with breast cancer, gave them a low energy density diet, substituting dietary fat for vegetables and fruits, and documented lower energy density out through 4 years. But despite that change, there was no difference in weight. And the other studies basically showed the same thing. And what about tastiness? This review by Johnson and Wardle concluded in humans, no studies have systematically manipulated dietary palatability to examine long-term effects on weight. There's similarly a lack of epidemiological studies examining associations between exposure to more palatable diets and weight change, meaning that direct effects on weight in humans remain untested. And ultimately, we have to deal with this paradox. What is it about? Why is the so-called body weight set point shifting up year after year among populations with stable genetic risk? In the 1960s, an average man might have weighed 75 kilos. If you overfed him to increase his weight by 15 kilos, he would feel stuffed, very unhappy, sweaty, highly satiated. His energy expenditure would go up. Once the force feeding was stopped, his weight would come down.
Right.
Today, you take that man who now weighs 15 kilos more and you underfeed to go back to that 1960s weight, he's starving. His energy expenditure slows, and once the protocol ends, again, the weight's going to come back up. The calorie in, calorie out view does not explain this. So we know that the problem isn't with the law of physics, but maybe it's about our assumptions of causal direction. According to the carbohydrate insulin model, we've had cause and effect reversed. The action is at the right. Fat storage leads to overeating. Now that might sound radical, but consider the adolescent growth spurt. In teenage years, a kid might consume hundreds or 1,000 calories more than he used to, and he's growing rapidly. But which comes first? Does the overeating make him grow? Or does the rapid growth with the deposition of those calories into new body tissue drive hunger and make him overeat? Well, it's obviously the second, because neither Bob nor I will grow any taller, no matter how much we eat.
I'm losing height.
And he's complaining about losing height. So the carbohydrate insulin model says that something has triggered our fat cells to hoard too many calories, and so there are too few calories in the bloodstream. The brain recognizes that, we get hungry, we overeat. If we resist overeating by a massive exertion of willpower, doesn't matter. Our energy expenditure will fall, we'll still have a positive energy balance. And so focusing on the left side of the equation is symptomatic treatment destined to fail. What could be driving this? Well, endocrinology 101, insulin. Insulin regulates the storage and metabolism of all of the fuels in the body. We know that, anyone who takes care of patients with diabetes knows that over-treatment with insulin, one of the first signs is weight gain. And a child with type 1 diabetes, before getting treatment, will inevitably have lost weight with an adequate amount of insulin. What could be raising insulin on a population basis? Nutrition 101. All the processed carbohydrates that flooded our diet during those low-fat years. This hypothesis is specifically focused on glycemic load. That's the combination of glycemic index times the amount of carbohydrate. The bottom line here is that the processed grains, but that also includes whole wheat breads. Most whole wheat breads that are refined into flour, those are still, even though they're called whole grain, they're still very fast digesting, and they'll raise blood sugar essentially as much as table sugar, maybe more. Potato products, added sugar, the minimally processed grains, the way grandma used to eat it, like whole kernel oatmeal, fruits, beans, and dairy are low glycemic load. So let's take a quick look at how these affect metabolism over the short term. In this study with 12 adolescents with obesity, we gave them in a reward study highly processed instant oatmeal, steel-cut oats, or a vegetable omelet with fruit. All of these had the same calories, and not surprisingly, we saw that insulin rose much higher after the instant oatmeal than the other two meals. whereas glucagon was suppressed by the high glycemic load meal. And as a consequence, that after that initial surge of blood sugar, under the anabolic effects of these hormones, blood sugar comes down rapidly into a relatively hypoglycemic range. Free fatty acids are suppressed to a greater degree. So we run out of metabolic fuels. And we get epinephrine surges, indicating that the body is under a true metabolic stress. We get hungry, and we eat more. Now that's a short study. Let's consider what happens over the longer term. In this study, we looked at diets that were low, moderate, or high fat. We brought weight down by 10% in a run-in phase, and then randomized and maintained weight the same during these 20-week test diets with 60-40 or 20% carbohydrate, 20-40 or 60% fat. We kept saturated fat as a proportion the same, so that the low-carb diet had a whopping 21% saturated fat. We'll come back to that. We saw the same drop-off in metabolic fuels in the late postprandial phase on the high-carbohydrate diet. And we saw that energy expenditure by doubly labeled water was 200 calories a day faster at the same weight on the low-carb diet. So same body weight. So the type of calories we eat could affect the number of calories we burn. If this effect is real and reproducible, it would explain much of the weight change that occurred as we shifted to these higher carbohydrate diets. The longest studies that control for treatment intensity, such as with food provision, do show substantial benefits to low carbohydrate diets. This is the Diogenes study in New England Journal of Medicine. There are very few studies that have appropriate treatment intensity, but the ones that do show consistently a benefit for carb reduction. So I've told you that the nature of the carbs that we're eating, we don't have to eliminate them, but the type of carbs are overstimulating insulin, driving fat cells to hoard too many calories, and that's leading to too few in the bloodstream, and that's why we're getting hungry. But this hypothesis is a conceptual framework for understanding how many factors beyond carbohydrate could be driving food intake as a secondary outcome. You know, for example, sleep, stress, endocrine disruptors might not be driving us to eat so much as changing our metabolism with a positive energy balance downstream. I think this is actually makes more sense than the way that we try to explain it. We have a full model of this carbohydrate insulin model, full diagram in the American Journal of Clinical Nutrition December issue. We paid the egregious open access fees, so get online, take a look, see what you think. What do we get right? What do we get wrong? In the last minute, I want to just focus on cardiovascular disease risk factors. Coming back to that feeding study, where we compared low, moderate, and high carb diets. The low carb diet, I told you, had a whopping 21% saturated fat. These patients had obesity at baseline, and many of them did after the weight loss. So their chief problem is insulin resistance. To me, that dominates their physiology. Saturated fat is a much lesser concern than the processed carbohydrates, and we see that here. This is one of the largest studies, 164 people over 5 months, a feeding study. No change in LDL cholesterol, no change in ApoB between the diets. However, lipoprotein insulin resistance, which reflects a composite of metabolic syndrome components, was markedly benefited on the low carbohydrate diet, and in opposition to the statement that diet does not affect LP(a), we saw a highly statistically significant benefit on the low-carb diet of reduction. Now, this wasn't a huge effect by absolute terms, but why are we neglecting, and this is consistent with many studies going back 30, 40 years, why are we neglecting diet as a treatment for high LPA, at least as an ancillary treatment? And lastly, I'd like to conclude with this thought that maybe these ideas are provocative, but they aren't new. A obesity researcher said that calorie restriction reduces the weight of anyone obese or lean, regardless of metabolic status, by opposing the homeostatic mechanisms for maintaining energy balance. A more rational form of treatment would be one which would enable the organism to establish homeostatic equilibrium between intake and expenditure at a normal level of body weight. The use of a diet allowing ad libitum intake of protein and fat and restricting only carbohydrate appears to meet the qualifications of such a treatment. And this was Pennington in the American Journal of Clinical Nutrition, 1953.
How about that?
Thank you for your attention. Please follow me on social media, and I'll look forward to discussion at the end.
All right, provocative, David, as always. Holly, you're last.
So I'm last.
Which,
Love it. Well, thanks for sticking with us.
Yeah.
Thanks for being here. I will stay on time, and let's see. I'm going to take a little bit of a different stance to this, a little bit of a different kind of act on this, and talk about that. I think it's a little bit more complex. I think for many, many years, we have in this field tried to say, what is the best diet? Is it low carbohydrate? Is it vegan? Is it DASH? Is it Mediterranean? We try to simplify it, in a sense, and say, what should we be providing? Is it American Heart Association? Whatever. That tends to be what we've done. And I've been participated in many of those trials, been involved, have been funded to do many of those trials. And I think to move the field forward at this point, we're going to have to take a little bit different direction. I think we're almost at a standstill in terms of what we're going to be able to learn if we keep going down the same path. So that's what my talk is going to be about today. There's my obligatory disclosure slide you've seen several times. And here's the game plan. So I'm going to spend just a couple minutes talking about, does a best diet approach exist? Is it really true? Should everybody be on the same diet? And what makes it more complex than that? I'm going to talk about what things do we need to consider when thinking about a diet approach for a patient. So let's get practical. Someone's sitting in front of you. What do you need to think about when you're going to decide what diet you might suggest for them? And I'm going to spend just one or two slides talking about where do I think we need to go next, because I do think we're at a pivotal place in the field, in the academic field, in terms of how are we going to spend our money and resources to try to move this question. What should we be eating? How are we going to spend our money and resources to move it forward? And then lastly, I always like to start with something you can take home, is how do you approach this topic with your patient today? It's confusing for us, and I think it's very confusing for our patients. So much information out there, and it's hard to figure out what can you say today? How should you approach it? All right, so I want to start with, does a best diet approach exist? And the first thing I always think about, and this always happens to me, I'm on the nightly news, and they give me, the 15-second sound bite, and this is the question. How do you answer this? And the first thing I always like to think about is, well, what the best diet for what? And that's part of the problem. The best diet for weight loss, meaning you need to be in a negative energy balance, and I still do believe you need to be in a negative energy balance to burn fat. The best diet to prevent you from gaining more weight, which is what we've seen in the population, right? Seeing that gaining weight over time. The best diet for preventing weight regain. Maybe they're not the same. It's all different in terms of what has to happen in your body or what might be going on in your body, so maybe it's not the same. Same thing when we think about cardiometabolic health. What's best for prevention? What's best if someone already has disease? That might not be the same diet. Cancer, prevention and treatment might not be the same. Sports performance, building lean mass. One of the things that my patients come in all the time and they go, put me on a diet where I can burn fat and put on a bunch of muscle. Oh my gosh, wait a minute. Those are opposite things. There may not be one diet that can do both of those things. The best diet for hypertension, we saw some DASH data already. Osteoporosis, fertility, pregnancy, cognitive function, anti-aging. There's so many goals, and perhaps the best diet doesn't exist or is different for those different goals. I always put this slide in because this is what I think about, the difference between weight loss and weight loss maintenance. And I believe that there are different diets for weight loss. There's different diets that work and will be successful in weight loss, and different diets for weight loss maintenance. And I think this just shows that you have to think about the goal. And if weight loss is your goal, it's a very different physiological state. Nutrition has to be there for certain reasons, and the best diet might be the diet that the person can adhere to for a short period of time, because weight loss can only occur for a finite period of time. Versus long-term maintenance of a reduced body weight, that's a different physiological state. You've got to be an energy balanced at a reduced body weight. And we know there's changes in physiology that push back. You have an energy gap that's created. What's the best diet to kind of fill that energy gap, or to take that energy gap into consideration? And so 2 different diets or types of diets. One diet might be better for someone to lose weight because it's very different than a diet that might be good for someone to maintain a weight loss. Just using that as an example. Lots of different diets out there, lots of different philosophies, from anything from the plant-based diets that are very, or can be very low fat, to higher fat diets, and everything in between. And where we've been in the field is, let's predict, or let's study, let's determine which one of these our patients should be on. And that's what we've been doing for many, many years. Just put this slide in to say we even got to add another layer of complexity to this, is I don't think that anyone just eats a diet in a vacuum. And so yes, a lot of times when we study efficacy, we feed someone the diet that we want, and we try to control for everything else. But does that ever exist? How does that data really help us? Because everybody's eating a diet, there's a certain amount of, for in this case, physical activity or energy through the system, or exercise, or whatever you want to call it. How might that affect the optimal diet? I believe the more physically active you are, the more leeway you may have in terms of having carbohydrates in your diet. You may be able to burn fuel. You will burn fuel differently. So the level of activity also could play a role in terms of what's the best diet, or this plate debate. So it is complex. We can think about things like age and sleep and stress, and you can make a long list to say, yes, probably all that interacts with the fuel we put in with our diet, and certain diets might be better for people at an older age that are sedentary with cardiovascular disease than other individuals at a different age with a different physical activity level and a different stress level. So it's complex, and how are we going to move this forward? We can't afford to study every single diet in every single situation. That would take forever, and we're not going to be able to do that. So how do we start to move this forward? I put this in here to say it's not what you eat, but how long you can eat it. When we do look at diets, it comes, I think I'm missing a slide. Oh well. When we do look at diets and look at this, you can see this was 4 different diets, and you can see a range of diets here in terms of what people did. And as you can see on each diet, you can see Atkins, Zone, Weight Watchers, and Ornish. There's a high range, a big variety. Some people gaining weight, some people losing weight. But when they look at what predicted who was going to do the best, meaning who was going to lose the most, and this is more of a real-world effectiveness type study, it was who could adhere to the diet they were assigned. So adherence even comes in. And adherence may involve physiology, but what else? It may involve behaviors and other things that we haven't even started to talk about. So this is a slide that shows that even on all the diets, adherence starts to fade over time. So in a sense, you're looking at adherence to a diet, and no matter what diet you tend to put someone on, adherence starts to fade. So we got to take that into consideration. So where are we going? There is a new study out. So Look Ahead has ended. Look Ahead is no longer being funded. So one of the new studies that the NIH has already funded is a large multi-center trial where it's awarding $170 million over 5 years to clinics and centers across the country for a study that will develop, hopefully, algorithms to predict individual responses to food and dietary routines. So it's a different way. It's not this head-to-head comparison. It's saying, can we start to phenotype and match people? That yes, there are some individuals that a low carbohydrate diet is wonderful for, and there's some individuals that a plant-based diet may be the best option for, and this diet may be better in this situation, and this diet could be better in this situation. How do we start to untangle that? So this is a different way to do that than we've been doing in the past. It's going to recruit a diverse pool of over 10,000 people to inform a more personalized nutrition recommendations. So can we start phenotyping? Maybe it's with a meal test, maybe it's with insulin levels, maybe it's with leptin. They don't know. They're going to try to cast a really broad net to say, can we start predicting? I think that's where we need to go instead of saying there's only one way, this is the wrong way, this is the right way. What if it's an and situation? And we just need to start figuring that and piece out. The other thing they're going to look at is not just physiology, and I'm in this group, and what I'm pushing for too is it's not just about energy balance, it's not just about hormones, it's about where you live, what you like, your behaviors. There's a lot of other contextual factors that can go in. So in addition to the physiology, we're also going to be putting those factors into what we're doing. The other thing that I just wanted you to be aware of that is coming out, something called the International Weight Control Registry. And it's going to be an online international prospective study to identify behaviors, and diet and nutrition will be some of the behaviors that will be looked at, associated with success or failure in weight loss and long-term weight loss maintenance. So this is pretty much geared more at the weight loss and weight loss maintenance question in relation to individual environmental, psychological, and biological factors. This is going to be a volunteer scientist partnership, and we're going to use AI to generate a whole lot of data to hopefully generate new hypotheses. So a different way, not your typical randomized controlled trial head-to-head, but saying, what are people doing? Let's look at totality, what they're eating, how much they're moving, their stress levels, where they live, what part of the country, how many kids they have, what do they like, all the things that come into may come into play into what diet works best for you in what situation, and can we actually use AI and some different type of techniques statistically to generate hypotheses that then we can test. So just two new ways that I think we're trying to move the field forward. So the idea would be we would set our goal, we would be able to do genetic testing, meal response tests, risk factor data, put in some preferences and feasibility, have a bunch of stuff that goes in, and then be able for an individual to actually spit out the best approaches. Not that there's one best approach, but what is the best approaches for the one individual in their current state. That's where I think we need to go. And so, how can you approach this topic with your patients today? I mean, what do you tell your patient now? This is great, Holly, these are coming, but what do I say? This is how I currently handle it in my practice. There's more than one evidence-based diet approach. I got into this field because I was a firm believer in a low-carb diet. I went to talk to Jim Hill, my mentor, about low-carb diets before anyone. Atkins was out there, but there was no studies been published in low-carb. I have over the years believed that yes, low-carb has its place, but so do a lot of other diets. That it's a very much of an and approach, that one size does not fit all. So I think options, and I tell my patient that, not an option, but options. And I think we have to get off on this like pointing fingers and saying that we're not open to, like there's some kind of conspiracy theory going on out here in the diet world. I don't believe that. So there's a lot of things I think people can do, and we just need to be a little bit more open to that. I have a toolbox of types of evidence-based approaches that I can suggest and support, so you need to do that. Can you help somebody who wants to go on a low-carb diet? Do you have tools? Do you know how to do that? What does that look like? Same thing for a plant-based diet. Do you have tools or support, or can you refer? Can you have multiple options? Consider the patient's health goals. Of course, that's important. Remember, it's their goals, not yours necessarily. What are they trying to accomplish by changing their nutrition? That's where I'm going to start to individualize it a little bit. And how long will they need to adhere to this approach? If it's for weight loss, I know it's going to be for a finite period of time. I'm going to be more open to a wider range of possibilities because it's for a finite period of time. Once we move into weight loss maintenance, and I'm thinking about it for a very long period of time, I'm going to have to look at data and make sure I feel like it's safe or advisable for them to be on this diet for years versus months. And I consider the patient's risk factors, their age, comorbidities, labs, family history. Consider the patient's preferences and lifestyle. Because why? Because adherence. If someone is a red meat eater and you say go on a plant-based diet, how likely do you think they're going to be able to adhere to that for how long? So preferences and lifestyle make an important contribution. So how do you approach this? Remember, adherence predicts success, at least when it comes to weight management. We have a lot of data to show that. Multiple diets can be successful, but which diet someone can adhere to does predict how well they do. Decide on one approach. Decide on it together with your patient. Reassess and don't be afraid to switch. If it's not working, try something else. It's okay to be wrong. We don't have this figured out in the field. And that makes, I think, us uncomfortable. But that's the truth. Use evidence-based options, but don't be so stuck in this has to be the way it is. What could we do? And like I've talked about in many of my talks up to this time, this really is the art of medicine. This is where you're helping them figure this out on an individual, not on these studies where you see the population, the average, but on an individual-based person. So the take home is evidence-based options. I always say that, yes. I'm not putting any of my patients on the cookie diet. That's not going to happen. I do individualize it though, and I change as needed over time. So thank you very much.
Thank you. All right, I want to thank all the speakers. We've got a few questions. I promise this audience will be done at 12:30. So I'd like to have about a couple of hours to discuss this topic because it's so interesting, so complex, so controversial, and I think keep in mind that the quality of the diet may be different than the quantity in terms of weight reduction versus cardiovascular disease risk. So, Monica, are you there?
I'm here.
Good. 3 nice presentations. Thank you all. The question, this first one really is directed towards you. It says, wonderful presentations. Of course, she or he's talking about all of us. But why do we as healthcare providers allow the sad diet, those are in capital letters, to continue to dominate for a large proportion of Americans? How do we change this culture for the benefit of all Americans? Your thoughts?
A good question. I think this all started in the 1960s and 70s, didn't it? When a lot of women went out into the workforce and we started looking for easier and faster meals. So sort of the instant meals and the highly processed quick meals became sort of much more popular. And now, yes, about 75% of the grocery store is arguably not optimal eating. I hate to say junk, but I might get in trouble for that. And so absolutely a real problem. What can we do about it? Yeah, I think it's going to take a lot of, there's a lot of data that shows that patients listen to their doctors. And so it troubles me that we as physicians don't counsel our patients on nutrition. And so I think the key is, as physicians, we need to just continue to emphasize nutrition and counsel our patients. I use a survey called the Starting the Conversation Survey that I highly recommend, that even if you're having, people say, well, I just don't have that kind of time, you can just have the patients fill that out when they first come in, and it becomes a conversation point at the end. And slowly, what I have found in my clinic is that people start changing their surveys. Either they're all lying to me, or the surveys are changing over time, where they're starting to think more about it as we have that conversation. I also always say to people, if you talk to the wife and the mom, and I know that that's a little bit of a bias and not to undervalue the role of the man or the husband in any family, or the dad, but often if you get to the mom, you get the family. So I think it's going to be step by step, these kind of things we have to educate. There's so much, revenue driven by instant foods, processed foods, et cetera, which makes it tricky, but slow and steady education of our patients. And, I appreciated the conversation about precision health, et cetera, but at the end of the day, in terms of cardiovascular health, we know that people need to eat more plants. And so if you just start the conversation about eating more plants every day, giving them suggestions, and even our meat eaters, and I'm in Florida, so our most complex meat eaters just need to sort of be shown options in terms of how they can eat more plants. Don't focus maybe on how to shift from one diet to the other, or just to add more plants.
Okay, and I think it's important to know that the DASH diet, the Mediterranean style diet, which are recommended by many nonprofit societies for cardiovascular health, ultimately are pretty plant-based. I mean, they're not entirely, plant-based, but they are. So the next question relates to us busy clinicians who have a lack of nutritional education. Helping support education of lifestyle and nutrition is tough in the clinic. Any thoughts of what we can do to enhance our understanding in nutrition, and ultimately how that might be applied to healthcare delivery, and what are the barriers that need to be put behind us. Holly, David, Monica, anybody? So we're talking about the clinician in the clinic.
Yeah,
What can he or she
I think it's just like any area that you're right. If you're recognizing, you're aware that you may not have the background that you need. I think we saw some of the data that wasn't necessarily, taught to us in medical school. It's just like anything, though. It's learning that. If you think it's important, then you gain information and you go places and you do CMEs on it and you become better at it. I think for the longest time, physicians especially didn't think nutrition was something you talked about. I mean, and definitely even obesity and weight wasn't something we talked about. when I first started this, people said, are you an MD and what are you doing? Are you really, that's all you do? You only talk to people weight? Are you a real doctor? And I'm like, well, yeah, I am. That's changed, and I think the same thing about nutrition is, yes, you have to educate yourself, and I think that some of this data that you've seen, my goodness, it's as impactful as giving a pill. So we take a lot of time to understand how to give a medication, to prescribe a medication. I think you have to spend just as much time, how do I prescribe a diet?
I mean, you've all alluded to this, and David brought it up in particular, but, lifestyle-related science is limited in terms of duration and patterns of restriction that need to be ultimately owned for a long period of time. A drug study's easy. You give a placebo and a drug, you got an outcome. But lifestyle-related science is difficult. David, this question I've often had, too. If insulin's the main driver of body weight, plus or minus, hence body fat storage, should we be measuring fasting insulin? I think I can answer that one, but I want you to do it. And what level of measurement is concerning, and how do we treat this insulin resistance as reflected by hyperinsulinemia?
Okay, so insulin is a key driver. It is the most potent anabolic hormone from the standpoint of body composition, but the dynamics are complicated. Both insulin secretion can reflect endogenous tendency or capacity. It can also can be also secondary to insulin resistance. So if you become resistant and your insulin levels go up, action in some tissues will be reduced. Whereas if you've got primary hypersecretion, such as stimulated by processed carbohydrates, action at key tissues will be increased. And then it gets even more complicated because you have muscle, liver, fat, and brain. They could all have different levels of insulin sensitivity. So measuring fasting levels is very coarse, and it's not going to really answer this question. We find in our research that insulin secretion, that's insulin level 30 minutes into an oral glucose tolerance test, is informative. That's been seen in multiple studies in my group, going down to either rodents to humans, and from a number of other groups. This is quite a vigorous finding in identifying individuals who will be especially susceptible to a high carbohydrate diet.
The role of insulin in the brain is physiologically to suppress food intake, but ultimately maybe insulin resistance in the brain no longer allows that metabolic effect to occur.
No, we know that's the case because brain insulin receptor knockout animals become obese. But the actions of insulin, if you give them peripherally, the peripheral actions dominate, including weight gain.
Okay, this is going to be the final question I'm going to ask the panel to address, and then we're going to close. So Monica, Holly, David, this question comes up a lot, this intermittent fasting and its impact on overall nutrition, body weight regulation, hunger, et cetera. Monica, quick answers from all three of you. Intermittent fasting.
So intermittent fasting, overall, most of the data shows that it's just calorie restriction in that situation, and that if you compare intermittent fasting to other diets, they all cause about the same amount of weight loss. There's some data in terms of ketones and whether those ketones are anti-inflammatory, which is interesting. I think the key on intermittent fasting is I use it for my patients where I tell them, what I find is that if I cut out their dinner and if I have them eat from breakfast until sort of 4 o'clock, they actually do end up eating less, and so I do appreciate that. Whereas There are other people, however, and you have to sort of remind people that they'll try to eat that same number of calories they were eating all day in that shorter amount of time, and the data hasn't panned out on that. But if you're able to get them to stop eating dinner and really not eating after that 4 or 5 o'clock meal, there is benefit. I have found benefit in weight loss.
So Holly, is this just one of the A to Z approaches? Go ahead, please.
Yeah, so I'm using this somewhat. I think that we don't have all the data we need on this yet. I think there's a lot of studies currently in play that will give us some more data on timed eating versus our intermittent fasting. Once again, it's for what goal? If you're specifically doing this goal for weight loss, I actually agree. I don't think it has a huge impact on weight loss. I do use it as a tool. I use it the exact same way that she was describing, where I stop eating at a certain point, and I do believe it decreases calories and can be a tool for that. I think there may be other things that it could be helpful for, though, not just for weight, other metabolic situations where it changes the physiology in some way that could be helpful for other goals, for other things. And so I don't think we completely know how we might use it yet.
Final comment, David, briefly, please.
Yeah, let's think physiologically, briefly. If you're eating a high glycemic load diet and you have high insulin levels, you're restraining lipolysis. Fat can't get out of the fat cells effectively. You try time-restricted eating, you're gonna crash. You're gonna be extremely hungry, metabolism will slow. If you eat a low-carb, high-fat diet and lower your insulin levels, you become fat-adapted. And your fat cells are more easily releasing of those calories. It makes time-restricted eating easier, and I'll complete on an anecdote. I was gaining weight just like everybody else during the pandemic. 6, 7 pounds, not 20, but it was stubborn and right on my midsection. And I started time-restricted eating. So I fast till usually 1 o'clock. Strong coffee in the morning. Caffeine is highly lipolytic, no hunger during the morning. If you're eating a low-carb diet, you have caffeine in the morning, no hunger, you have a lunch, and then I have a nice big dinner, which can include carbohydrate, and that extra, anecdotally, those pounds just melted off.
Okay, well, thank you. I want to thank all the panelists. We have a few closing slides. If we can get the slides up, please.